Scenario, your time starts now. You have a 60-year-old man presenting with difficulty in passing urine. His IPS score was 25 out of 35 with QOL of 4 out of 6, and you have gone through his examination, everything. His prostate is 20 cc, and he is quite bothered by the symptoms. You have given him no neurological findings. You have given him tamsulosin, which helped him. But in the next clinic, when he visits, he is explaining significant problems of anejaculation, and that's where he presented for the second time. So why anejaculation happens with tamsulosin?
Risk of ejaculation with tamsulosin, it was found to be around 6 to 9%. And this is recognized side effects of alpha blockers, and it happens, with all alpha blockers, but it's less so with the tamsulosin. Although it still does exist.
Okay. So what is the mechanism behind the anejaculation?
It's just I think it works by smooth muscle relaxation. So opening the bladder neck or relaxation around the bladder neck, and therefore it will be some retrograde ejaculation from my understanding.
Okay. And so how are you going to treat this gentleman?
So I will counsel him about that is a recognized side effects of alpha blockers. Given his bothersome symptoms, I will counsel him about different modalities of treatment. Obviously, if he's still concerned about his sexual function, then I can revisit the avenues of conservative measures again, or change the medical therapy to different therapy. Depends on his predominant symptoms. If it's a storage symptoms, I can counsel him about anticholinergic or beta-3 agonists. I will take a baseline history and assessment of his erectile function. I will provide him with the SHIM questionnaire and ask him to complete it and have that as a baseline. Depends on his SHIM questionnaire. We'll be able to counsel him if he can benefit from, if he does have evidence of erectile dysfunction from the SHIM questionnaire. I can counsel him about PDE5 inhibitors on a daily dose, such as Tadalafil. This has found evidence by the NICE guidelines and EU guidelines to help IPSS parameters and Qmax.
What is the SHIM questionnaire? What are all the components in
it? The SHIM questionnaire, that's the International Index of Erectile Function 5. It's 5 questions from 1 to 21. The higher the score, the better the erectile function. It's 5 questions, assess the confidence of erection, the overall satisfaction. If the patient's able to maintain erection to penetrate, if he's able to maintain erection after penetration, if he's able to maintain erection after completion.
Okay. What is the dose you will give Tadalafil for him?
After counseling the patient and ensured he does not have any contraindication, the daily dose of Tadalafil is 1 milligram once a day.
How much is that? Sorry?
5 milligram.
Okay. What is the NICE guideline stance on Tadalafil monotherapy?
NICE guidelines only approve PD5 inhibitors monotherapy in patients with LUTS and ED together, but does not approve it with LUTS only.
Okay. How are you going to follow up this patient?
Once I start him on the treatment, I will see him back again in about around 3 to 4 months' time with the repeat IPSS score, SHIM score, and flow rate and pulse with residual, assess his symptoms, and depends on the progress, I will counsel him accordingly.
What is the complications of long-term untreated male LUTS or benign prostatic enlargement?
The long-term consequences can be recurrent UTI, bladder stones, recurrent hematuria, acute renal retention, blood diverticulum, and high-pressure chronic retention or renal failure.
Okay. What is the chance of a patient presenting with acute urinary retention in this group of patients?
What is the what, sorry?
Risk of this patient presenting with acute urinary retention.
The risk of that will be between 2 to 5%.
Okay, say for example a patient who was not treated before presenting with acute urinary retention, how are you going to treat him? Examination wise, let us assume his prostate is like 30 cc, no other neurological or any other problems.
If he has presented
With
not being
acute,
treated
with acute urinary retention.
with acute urinary retention, okay, I see. So if he's presented acutely with acute urinary retention, I will see him without delay, especially if he does have any risk of sepsis, any history, or from the examination and symptoms, any risk of renal impairment. Will ensure that he's catheterized, measure his post-void residual, and ensure that he has urinary checked. If he does have a history and examination suggestive of acute urinary retention with normal kidney function, we'll counsel him about starting alpha blockers, such as tamsulosin 400 micrograms once a day. I will arrange for him to have a trial without catheter in a week time. We know from the alpha study the risk of one of the parameters which was studied is TWAC after a minimum of 3 days. But in my practice, due to logistics and waiting list, the earliest TWAC slots around a week or 2. So I will arrange for him to have that in the next available slot. From the history, again, I will just ensure that whether he does have a spontaneous acute urinary retention or precipitated acute urinary retention.
What drug used in Alford study?
Alvazocin was used and it was compared against placebo.
Okay. What is the importance of differentiating spontaneous and precipitated urinary retention?
With the precipitated acute urinary retention, the chances of passing TWAC is higher compared to the spontaneous retention, and the chances of needing surgery is lower. It's at 25% in this precipitated group compared to 75% in the spontaneous group. So in essence, the precipitated do better compared to the spontaneous group.
Okay, what are the indications for surgery when you are following these type of patients in long term?
Indication of surgery, recurrent UTI, symptoms refractory to medical treatment, recurrent visible hematuria, recurrent presentation with acute urinary retention, picture of high pressure retention, and bladder stones.
Okay, and compared to the normal medications for erectile dysfunction, how the dosage in BPH differ as far as PDE5 inhibitors are concerned?
PDE5 inhibitors such as Tadalafil can be given only, to my knowledge, with tamsulosin after 48 hours, but it cannot be given with doxazocin if patient on doxazocin. And the benefit is shown benefit to be given combined together for a patient with limited tract symptoms.
What is the normal dose of Tadalafil if a patient presenting with monosymptomatic erectile dysfunction?
The PRN dose, maximum dose up to 20 milligram, and can be given at 8 doses, obviously 1 dose at a time, as a PRN regime.
Okay, so your time completed now. So for Tadalafil is given as 20 milligrams PRN, as you said. You can give Tadalafil 5 milligram and a combination of tamsulosin 400 microgram. Just since both can cause postural hypertension, maybe you can give Tadalafil in the morning and tamsulosin in the evening. You're again maintained very good standard in the third scenario also. The only thing is the reason for anejaculation is not necessarily the bladder neck relaxation alone. It could be even the relaxation of the ejaculatory duct, and so the ejaculation is not happening. That's why the terminology is changed from retrograde ejaculation to anejaculation. You are good with SHIM scores, but if you see the SHIM scores, say for example that 5 stages where you are quantifying, you can easily remember in that coherent order, like for example interest to have sex, adequate erection before penetration, able to penetrate and perform well, able to penetrate till completion, and overall satisfaction. So in the same order how a normal sexual intercourse happens. So you can be a little bit more sleek in that. And as you said, higher the score, it's good news when compared to IPSS score, where higher the score means the symptoms are bad. Indirectly, in IPSS score, we are quantifying the symptoms. In SHIM score or IEF score, we are quantifying the normal erectile function. That's why the score should be good for good erectile function. After discussing this anejaculation, everything, when I want you to proceed towards the Tadalafil, you discussed the conservative treatment again. Nothing wrong in it. Maybe it's a separate scenario, that's why you made it. But in continuation, usually conservative treatment failed, alpha blockers failed, patient had erectile dysfunctions. That's why you're thinking about tamsulosin. Regarding the NICE guideline stance on tamsulosin, it is 5 milligram once daily, and it has to be used only in randomized control study, not in the routine practice. One factor which you missed in the complications that can develop in an untreated male LUTS is recurrent hematuria, or the recurrent hematuria may be one of the reasons to jump into the surgical modalities.
Okay.
You are correct in differentiating between precipitated and spontaneous retention. Precipitated patients have got a specific cause like overhydration or alcoholic episode, something like that. So they do better because there is a precipitation cause, while spontaneous acute urinary retention patients have no reasons for precipitation, so they fare slightly worse in the success of trial ward without catheter. They may end up in surgery more frequently. And untreated LUTS can also cause increase in creatinine, loss of renal EGF, renal nephrons, and loss of EGFR. So that's another thing you need to mention. Okay?
Yeah.
Good. Well done. Any other questions? We have finished the medical management in these 3 scenarios. Any questions you have?
No, it was very good. We recapped good things. It's good to to bring in these patients with like a storage symptoms and coexisted erectile dysfunction. So be prepared of all possible questions that the panel can ask you. So these are good scenarios. Yeah, thank you.
Good. Can I open the discussion for others to ask if they have any questions? Okay, Sami?
Yes, please.
Any other exam going candidates online? If you have any questions or doubts, you can ask now. Our next scenario or the next class will be on the surgical treatment options for male LUTS or BPH. Okay, if there is no other questions, we will conclude the session today. Thank you, Sami, for your time. We hope we do as many sessions as possible and complete the scenarios at least 2-3 times. Okay.
No, thank you. Thank you. Just one last question,
Yeah.
Sidi. Just about, I don't know if I phrase it correctly, to bring in the urodynamics, even though if there is an indication from the history and the findings, the patient can have a urodynamics. Should I jump in straight away that?
Nothing wrong in it. As you correctly said, the urodynamics indications are very, very clear. Extremes of age, less than 50 years or more than 80 years, previous surgical intervention, and Qmax is more than 10, but patient has got significant LUTS. So there is a mismatch, isn't it? Patient says patient has significant LUTS, but Qmax is more than 10. That means he's voiding, but he's still symptomatic. So we need to get into the bottom of the problem. Predominant storage symptoms and previous history of any neurological disorders. You can jump into urodynamics if any of these factors present even in the initial presentation, nothing wrong in it. But in general, uroflowmetry is enough for initial quantification and preparation.
Yeah, okay.
Good. Have a good evening and prepare well for the surgical management. I will send you the dates soon.
No problem. Thank you, Msadi. I appreciate your time.
Good. Bye.
Thank you. Bye-bye.